Thank you for coming to my presentation today, actually to all of our presentations. Hopefully you've been able to learn some things throughout the day. So I chose to do my presentation on the impact of prophylactic enteral nutrition in cancer patients. And just quick show of hands, how many of us have been affected by cancer through a family member? All right, how about through a friend or someone that we know, through somebody else? All right, so I'm pretty sure I saw pretty much everyone's hands go up. So, and even if there wasn't somebody who put up a hand, we see constant news coverage on this topic as far as cancer, as to what we should be putting in our bodies or putting on our bodies or keeping out and away from our bodies that could cause increased risk to cancer. So that's why I think that this topic is really prevalent to everyone, because cancer truly does affect everyone. So I have it right there. Cancer affects everyone, so that's one of my reasons for research. In the United States alone, we see over 2 million new cases every year. And out of those cases, we often see that over 600,000 of those result in death. So it's definitely substantial. We know that malnutrition is a common side effect of cancer. This is due to the fact that they're receiving treatment and possibly medications that could cause some side effects, such as dry mouth, loss of appetite, nausea, and vomiting, that could be also a concern for dehydration in this population. Head and neck cancer is especially at high risk for malnutrition, and we see that over 20% of deaths in cancer are related to malnutrition. So my question that I had throughout this study was what we can do as dietitians to help reduce this risk of malnutrition in our patients. So this is a figure that I adapted from an evidence-based review on this topic, and it just goes over the impact of nutrition intervention on cancer. So we start off with early access to the necessary care. If I can get this, there it is. So early access to necessary care. So this is through the form of that screening and assessment by hospital staff to help make sure that those high-risk populations are being seen by the dietitian. We then move on to quality nutrition care with that nutrition intervention. This can be through the form of supplementation, possible diet modifications, or enteral nutrition if necessary. So once we get that quality nutrition care, we see overall improved nutrient intakes and improved intermediate outcomes. And this can be the changes in a person's physiological and biochemical markers. From there, we see improved clinical outcomes through the prevention of malnutrition, and this could be because we're helping minimize those side effects that they might experience with their disease treatment. We then move on to see cost outcomes, and this is because we're helping reduce and minimize that hospitalization. So we're making sure that the side effects are managed so that hopefully patients aren't being admitted to the hospital based on malnutrition or dehydration. And finally, we see the overall patient outcomes, which is an increased survival rate and quality of life, because we are helping to minimize those discomforts that they may experience, disabilities, and overall just managing their disease state as best as we can on our end. So when I'm talking about prophylactic PEG, we all know enteral nutrition is giving people the necessary care that they need as far as meeting their nutrient needs. So that's what this is making sure that patients are receiving nutrition intervention as early on in their treatment process as possible. It's known that enteral nutrition, and that's any form of enteral nutrition, helps to increase protein and energy intake in any patient. And this is compared to oral intake alone. It's also associated with a prophylactic PEG that there would be a decreased weight loss of these patients due to the management of their side effects. Prophylactic means that we're starting earlier, so making sure that we are catching the patients who are high risk early on to make sure that then they're not at risk of becoming malnourished. It's also related or associated with patients on an enteral feeding tube for a longer period of time. However, we can bounce back to their starting earlier, so those two things can contribute to each other. Overall, they're looking for better maintenance of quality of life through the management of their side effects and their overall disease. And the goal then is to help reduce those hospital admissions, making sure that patients are being treated as best as they can ahead of time. So just a quick review, when we're talking about a PEG tube, we're talking about it going through the abdominal wall into the stomach versus an NG tube going through the nose, down the esophagus, and then into the stomach. So my first study is the impact of early prophylactic feeding on long-term tube dependency outcomes in patients with head and neck cancer. This took place in Australia and was published in 2017. So here they were studying the long-term effect of tube feeding on patients with head and neck cancer. This was a randomized control trial with the inclusion criteria being those head and neck cancer patients who were referred for a PEG tube. And then the exclusion criteria were those who had a non-curative intent, were already malnourished, or else had severe dysphagia that resulted in early enteral nutrition already. Measurements were taken, the study group was the early intervention, so with that prophylactic PEG, and then the control group was considered to be the usual care or standard care, so giving them the tube feeding when they thought it was necessary. Measurements were taken at the end of treatment, and then 1, 2, 3, 4, 5, 6, and 12-month follow-ups. And what they were looking for was the actual use of the tube as well as the rate of removal of the tube. So when they compared for the results, they found that tube removal was not significant between the two groups. It was a matter of 100 days in the study group, so that reactive approach, versus 110 days in the intervention group. So this was found to be not significant. They found that when they removed the patients who did have a persistent disease state, that there was a slighter bit difference, but again, not clinically or statistically significant between the two. And then they also showed an increased use of the tube during that really acute time frame. So that's the first 3 months of treatment, when they're often feeling the effect of a lot of the side effects. So this graph is showing the use of the tube over a 12-month period. So along the bottom are the months of post-treatment, and we're comparing standard care to intervention. So every two is comparing that month. So along the side, we see the percentage of patients, and we're discussing either full use, supplementary use, no use, or removed. So that's in the blue, orange, gray, and yellow. So at the first month, we see that both are hovering right around that 70–75% of full use. And then at 1 month, and we're looking at standard care versus intervention, we see that they're both hovering around more like 30–35 use. And we continue to see them decrease and stay pretty neck and neck with each other. And here, there was no statistical significance found between the two. So overall, I found this to be a positive study based on the EAL rating. For strengths, they were studying actual tube use rather than tube presence, which is really important because just because a tube is physically there does not mean that it's being utilized. So a patient could be on a wait list to get it removed or waiting to hear it on their prognosis to know whether they're going to need it in the future. So it's really important that they were looking at the actual use of the tube. They also made sure to randomize patients into groups to make sure that they had a variety of patients with a variety of disease states to help minimize any differences. And lastly, they discussed the role of the dietitian heavily when it came to the PEG referral as well as the follow-up treatment. Some limitations, they were not assessing or measuring swallow function of the patients, so it's difficult to know the level of improvement that they had throughout the care and then when they got their tubes removed. And in addition, because feeding tubes are associated with a lower quality of life, they did not have one in it, and so this really should have been something that they should have used as an assessment. So the takeaways I had from the study was that the prophylactic PEG really was useful during that acute phase. They showed that many of the patients were using their tubes during that first 3-month period when nutrition is really necessary. They found that it may prolong time, however, it was not found to be statistically significant. And lastly, just the importance of involving the patient for their input. Again, finding out whether they're actually using the tube versus if it's just there because they're waiting to have it removed or if they need it for a longer period of time. So then my second study was the impact of prophylactic gastrostomy or reactive NG tube upon the patient-reported long-term swallow function following chemoradiotherapy for oropharyngeal carcinoma, a matched pair analysis. This took place in the United Kingdom, and it was published in 2016. So here they were looking at the long-term swallow function. They were using a retrospective cohort study with a matched pair analysis. And the inclusion criteria were those who had stage 3 or 4 head and neck cancer, had a curative non-surgical disease treatment technique, and then also were disease-free for a minimum of 2 years upon follow-up. The exclusion criteria were those who had a recurrent disease, or else if they had enteral nutrition prior to their treatment. So the study group was, again, that prophylactic PEG tube, and the reactive group, or the control group, was a reactive NG tube. They did their assessment utilizing the MD Anderson Dysphagia Inventory, which is a self-assessment tool for cancer patients to measure their level of dysphagia as well as their swallow function. So overall, the control group, being that reactive NG tube group, did report higher swallow functions. However, they also found that the more normalized or regular the pretreatment diet was, that the better MD-ADI scores came. And then overall, they found that the prophylactic gastrostomy resulted in a lower MD-ADI score. So here we're looking at those scores. So along the bottom are the subscales. So we have the total, and then these are the subscales of global, physical, emotional, and functional. I've abstracted the ones that were found to be significant. So, and then the score value, it went up to 100, but because nobody scored 100, my graph cut off at 80. So as we can see, total, global, emotional, and functional were all found to be statistically significant, and that reactive NG group is in the yellow compared to the prophylactic gastrostomy in the blue. So I also found this study to be a positive study. Some strengths of the study was the use of that MD Anderson dysphagia inventory. They had comparable baselines in both groups. So this is really crucial when we're looking for clinical significance. We want to make sure that we've minimized the differences. And in addition, the study design did allow the researchers to make sure that the differences were eliminated as best as they could, so that then they could focus on that single outcome they wanted to look at. For limitations, they did not have any information on the current nutritional status of the patients upon following up with them at least 2 years after. They also had patient-reported results, so this could be biased because the patients are reporting on their own functional status. And if they weren't really happy with the placement of their tube or how they were utilizing it, this could have affected their results. In addition, it was unclear the level of nutrition intervention and counseling in this. So because we don't know how much they discussed the use of the tube or when they discussed the use of the tube, it's entirely possible that the patients didn't know the proper use, and so this could have also affected the way that they were reporting their data. And lastly, they were comparing an NG tube to a PEG tube, which the differences, the advantages and disadvantages are different for both of them, one being just the length of time that a tube is used. So this could have also adjusted the results. So the takeaways that I had from this study was making sure to assess in a time frame that allows for optimal healing. So this study in their discussion talked about how swallow function improves past 12 months, and then overall salivary function plateaus at 2 years post-treatment. And then overall, the prophylactic gastrostomy had a less than positive effect on the long-term swallow function according to this study. So my final study was the impact of the prophylactic PEG on malnutrition and quality of life in patients with head and neck cancer, a randomized study. It took place in Sweden and was published in 2011. So here they were studying the benefits of the prophylactic PEG in the prevention of malnutrition. They had a randomized controlled trial, and the inclusion criteria were those who were newly diagnosed, untreated head and neck cancers, who were stage 3 or 4 and were planning treatment with a curative intent. And the exclusion criteria were those who were planning for palliative care or were unable to answer quality of life questions. So the study group was, again, that prophylactic PEG tube compared to the control group, which they defined as clinical practice, but it's standard care. So assessment took place at 1, 2, 3, 6, 12, and 24-month follow-ups, and then they also had the baseline. So when they looked at assessment, they were looking at the nutritional assessment, which was looking at the BMI, as well as the level of malnutrition in the patients. So malnutrition was defined as greater than 10% weight loss within a 6-month period. Clinical assessment was looking at the dysphagia that the patients were experiencing. Performance was utilizing a Karnofsky performance scale for physical function. And this was on a scale of 0 to 100, 0 meaning it was they were deceased, and 100 meaning that they were normal, no evidence of disease, no issues. Quality of life questionnaires were utilizing the European Organization of Research and Treatment on Cancer. They utilized 2 of them, the C30 and then the H&N35. So the C30 was cancer-specific, 30 questions, and the H&N was head and neck cancer-specific with 35 questions. And lastly, they were looking at tumor treatment, basically if they were being treated surgically or in a combined therapy sort of way. So overall, they had 97 patients complete the trial, with 49 in the study group and then 48 in the control group. They found when they looked at the enteral nutrition that the study group utilized the tube for a longer period of time. It was a difference of 177 days in the study group compared to 122 in the control group. However, they did not declare this as statistically significant. And they also found that on average, the study group started 23 days earlier. They found that the dysphagia increased in both groups throughout the first 3 months, and then it declined at 6 months and further declined at 12 months. And overall, in that time, they found that the study group showed better outcomes. They found no difference in hospital stay time. And as far as the quality of life questionnaires, they found that the study group consistently and significantly reported better results throughout the entire study. So here we're looking at the percentage of weight loss. We have the percentage along this side, and then the blue line indicates the study group, and the yellow line indicates the control group. And we can see that the greatest amount of weight loss was at 6 months, and that was found to be statistically significant in the difference between the 2 groups. And then they both decline. Here we see that they swap. Here we can look at the percent of patients with a BMI less than 20. So the study group consistently had a higher percentage of their patients with a BMI less than 20 compared to the control group. However, this was not considered to be statistically significant. And then the percent of malnourished patients. So at baseline, they had none, and then they continued to go up in both groups. And as I said, at 6 months, they began to drop off. That was with dysphagia. But yeah, they found no statistical significance between these 2 groups, though. So some strengths of the study. They had a large study population, so they had over 72% of their original participants end in the study. They utilized the validated assessments through that European Organization of Research and Treatment of Cancer. And they were utilizing patient-reported data as far as their physical and functional status compared to clinician, which when it's clinician-reported data that's objective like that, oftentimes they underestimate the patient's physical and functional needs. So some limitations, they had clinical praxis as far as the nutrition care undefined, so it's hard to know what patients were getting as far as care in that way. We saw overall higher survival rates in the study group, which if we look at the fact that more passed on earlier in the study in the control group and then were overall removed, those could have been the more fragile cases, and then those could have skewed the results, making the control group look stronger compared to the study group. Another limitation is the limited differences between the 2 groups. Because we don't know the level of nutrition intervention and care that they were getting, it's hard to know how much of a difference, other than the fact that it was a reactive versus prophylactic PEG placement. And lastly, they had no explanation for the higher percent of weight loss and malnutrition in the study group compared to the control group at 24 months, which I really would have, I think it would have been good for them to discuss. So the takeaways that I had from the study were that the earlier start, that may help reduce the risk of malnutrition. As we saw at 2 months, that the study group had less. Overall, we saw an increased quality of life in the study group compared to the control group. And the nutrition counseling that both patients received helped overall improve the outcomes of the patients. So the conclusions that I drew based on my research were the fact that completing enteral nutrition education early prior to treatment would be of benefit, because this helps make sure that the patients are aware of the proper use of their tube prior to them actually needing the tube. In addition, we can at least discuss with placements the option of placing a tube prophylactically based on these study results. We see that at 2 months, again, they found in study 1 and 3 that patients had significantly less malnourishment during that time. So this would be something that we could at least let our patients know about and give them the option of starting early. And lastly, being an advocate for the dietitian's role. No matter what area of study we are in, this area just showed the benefit of that nutrition intervention, but we see it across the board in all areas, whether it's diabetes, cardiac health, anywhere. We see that there's a benefit to that nutrition intervention. So there are my references. Thank you all for coming and listening through my presentation. I hope it was educational. As mentioned earlier, at that link is where the presentations will be available, and I'm happy to take any questions you may have.
Did they discuss ongoing speech therapy during these trials?
They did not, no. That's something that would have been interesting to know. Steven?
Did you look at all the differences between like how we do things in America as opposed to Australia, where they have like the just standard care?
No, that probably would have helped to find out though what that standard care might have looked like. Granted, it differs hospital to hospital, but no, I did not look at that difference. Mainly looking between the difference of prophylactic versus reactive. So, yeah.
There was a slide talking about the dysphagia increase in both groups.
Mm-hmm.
Why do you think that is?
I think just in general because the side effects of the treatment and medications that can occur. So you'll see that dysphagia increase, but then it's a matter of using a speech therapist and stuff like that to help make sure that we're using those muscles regularly throughout treatment. So that would have been something that if they had had speech therapy involved, maybe it would have been limited, or perhaps they did, but they just didn't discuss it. But yeah, it's just kind of normal with patients with head and neck cancer. Any other questions? Well, thank you everyone. I really appreciate it.